Hello everybody and welcome to our Teoxane Symposium of the day. The title is How to Bring Your Treatment Planning to the Next Level, and we are thrilled to have Dr. Benji DHILLON presenting this webinar for us. And I'm sure all of you already know Dr. DHILLON, but I'll just make a quick introduction. Dr. DHILLON is a plastic surgeon in the UK. He's a world-renowned injector and has been mentored by world-renowned injectors. He's the founder and director of the Define Clinic that is based in Beaconsfield in the UK, and that is bringing together the world of cosmetic medicine and cosmetic dentistry. He is a global key opinion leader and an international faculty member for Teoxane, and we are really happy to have him working with us. Before I leave the floor or the screen to Dr. DHILLON, I just wanted to give you a few instructions on how to interact with Dr. DHILLON. You can see that there is a Q&A section at the bottom of your screen, of your Zoom screen. So do not hesitate to ask questions to Dr. DHILLON in this Q&A tab, and we will have some Q&A sessions during the webinar that Dr. DHILLON will answer them. So Benji, thank you very much, and thanks again for presenting this webinar with us.
Thank you, Fabienne. Thank you. So hello to all my friends and colleagues from around the world, wherever you are. I'm really delighted to be hosting this webinar with Teoxane. And what we're going to be exploring over the next sort of 45 minutes to an hour is how to elevate aesthetic treatment planning. Now, for those of you that know me well, I'm a big believer not in teaching, but sharing. I don't think there's ever any right way, unless it's anatomy, to do things necessarily. So I'm just going to share with you my approaches to aesthetic treatment planning and share with you an algorithm I've developed and put together, and hopefully it's of some benefit to all of you and stimulate some discussion. So moving on, most importantly, I hope everyone is safe and well. We're in very unprecedented and strange times. I believe myself and for all of us on the webinar around the world, it's made us really sort of truly understand what's important in life, spending time with family, taking the important things, not taking the important things for granted. But it's also been a really invaluable time to learn and attempt new things. So in between managing a lot of other things, I am using this opportunity to try and expand my thinking in some areas. And hopefully I'll share some of that with you today. But I do believe a lot of what we're doing now allows a new world of possibilities when the world does reopen. And I think as an industry, we're all positioned to really help each other out and try and make ourselves successful again once we can. So as you can probably see from my background, that isn't my house, it's our clinic in Beaconsfield, and I've got a virtual background. So really delighted to be here. So let's get into it. I'm a big believer that as injectors of both toxin and fillers, we must really make a decision on what type of injector we want to be. Now, there is no right answer for this. I know fantastic injectors that who get beautiful results with 1 or 2 syringes as standard and on average for every patient that walks in the door. They do very well both from a patient outcome, but also very well from a business outcome. But I do believe we've all got to make a decision whether we want to be that, or we want to be focused on being multi-syringe, multi-session injectors that can focus on harmony, beauty, and proportion. Now again, please, neither of these are right, but I think it's something we have to stimulate ourselves to really think about. My personal approach to injecting and my philosophy is multi-syringe, multi-session injectors for the right indications that is appropriate for treatment for the patient. Treatment planning, however, is the final step in our journey, and we're going to go into the journey a little bit during the course of this webinar. I do think it all starts off with a lead or an inquiry. I'm going to a lead because this is when a patient has contacted your clinic, your team, your telephone staff, for example, have spoken to them. But the important thing for them at that point, and this requires some training for your staff, is for them to understand what are their concerns and what have they had done before. Have they had any treatment done and what are they looking to achieve now? And often the patient will say one or two things, maybe focus on a single area, but it's really important you're armed with as much information before that patient comes in through the door. Now, a consultation is of absolute importance when it comes to deciding what you're going to do for that patient that keeps them satisfied, helps yourself as well from a patient outcome, but a business perspective as well. In the consultation, I believe that the things to focus on are really priorities and expectations. What is it in terms of the list of priorities the patient wants to focus on? What is their number one priority? What's their number two? What's their number three? And you've got to tease that out of the patient because they may come in asking for something, but when you dive into it in further detail, that's actually probably a lower down priority than something else they've discovered. Now, the worst thing we can do is treat that lower priority. They go home, they say you haven't treated the thing that they really wanted. Also ascertain their expectations. We have all been there as a community where someone has come in, expected a surgical facelift result with a couple of mils of filler. And we've got to really understand that and understand, is that patient appropriate for the right type of treatment? And this comes down to us to elicit this information. The last thing is treatment planning. Now, this is where patients' priorities are played off against their aesthetic priorities. And I think as a community, we sometimes defocus what we believe, us, the professionals, us, the experts, that is appropriate for the patient. We're so focused on understanding the patient's priorities. We are, however, trained. We spend a lot of time as a community going to congresses, learning of what really should be done for that patient to maintain balance, harmony, and beautification. And we can't be afraid to share that with the patient because after all, that is what is coming, that is what they are coming to you for. They're coming to you for your expertise. We've got to take ourselves out of their comfort zone and suggest the things that they don't see that you think is appropriate. Now, this is where education comes into play. We've got to educate the patient to make them understand why you're saying that. And I'll go into that in a little bit more detail. Now, aesthetic consultations are very much a balancing act. And I know this for a fact. My business partner is a cosmetic dentist and a co-founder of the clinic. And I've sat in dental consultations. I've seen they also have a balancing act. When it comes to aesthetics, a lot of it is balancing a few different things. On the patient side, it's their priorities. I come back to the priorities. But as practitioners, we are balancing so many things at the same time. We're balancing trying to get a really outstanding aesthetic result for that patient. What are our aesthetic goals to get them a beautiful aesthetic result? We're also balancing financials. At the end of the day, we are all businesses. We run businesses. We employ teams. And I'll be very honest, and I'm sure a lot of us have been in that situation where you maybe have had a lot of new patient consultations. You probably, some of them may not have converted yet, and you're thinking, wow, I haven't earned as much money as I needed to. And we feel sometimes under pressure where we've got to maybe sell multiple syringes or treatments, but we've really got to balance that off against the aesthetic goals. I'm a big believer in investing in the long term and not the short term. We're also balancing patient retention. We're very scared sometimes around, I know I've been there, a patient walks in and you think they may need, or I think they may need 7 to 8 syringes of treatment. You know that's not going to be cheap. You don't want to lose that patient. So how do you ensure retention? How do you make sure they come back for that treatment and then become a long-term patient of yours? And then also for those of us with other treatments, other devices, what are the upsell opportunities, whether that's skincare, laser-based or other device-based treatments? So we are balancing so many things and we've got to become experts in this balancing act. So our focus must be, however, on anatomy. Now, this comes back to, yes, treatment planning is really important, but for us to be really good at treatment planning and developing a unique treatment plan, we have to understand the essentials. Number one is anatomy, anatomy, anatomy. And I know Our great colleague, Dr. Patrick Trevedich, is a fantastic anatomist. And, you know, I don't think there is anyone better placed that I know who can make really complex things simple and applicable and practical. But anatomy is really what is central to this, as you'll come to see. Understanding technique, understanding what and how are you going to use the products to reach the anatomical target you need to, maintaining safety as much as possible. And then finally, product. Different products should be used in different patients with different indications based on the anatomy and the requirement. So it's a fine balancing act between these, and we've got to focus on these first before we get to treatment planning. But our focus must also be on the consultation and the treatment plan. How do we package this all together to be able to deliver a very unique and comprehensive treatment plan for our patients that educates them at the same time? So in my opinion, there are three key fundamentals to consultation treatment planning. Number one is understanding the patient's priorities. Number two is face shape, and I'll come on to this in more detail. And number three is patient education. I believe, in addition to anatomy, technique, and products, if we focus on exploring these with our patients, then we can come to a really unique and very successful treatment planning algorithm. So let's dive into this in a little bit more detail. Patient's priorities. How many of us have come across a patient like this who comes in and says, I don't like my nasolabial folds? You see no nasolabial folds and you see something completely different, but that patient hasn't highlighted or requested a thing that you see. That happens all the time. There's a lot of deep data out there that talk about how patients are often focused on one area. Nasolabial folds, tired eye, sagging jawline, thin lips are very common things for them to present into our clinics. And this is because they are subjective. I take myself as an example. I'm always focused on my lines on my forehead, but I believe if I apply my objective eye, that there are other things I could potentially treat instead. We are always subjective as patients. We focus our eyes on one thing only. But however, you are the objective person. You are the expert that can analyze the face and understanding what should be treated to elevate the patient's aesthetic. We must, however, be able to look at the big picture. And this is why I come back to looking at the patient. I talk about harmony and balance, looking at the patient's face in entirety, not focusing on just what they have asked you to look at. Take a step back and let's analyze the complete painting. How can we elevate the aesthetic of that painting? At the end of the day, we are scientists, we're anatomists, but we have to combine it with some degree of art as well. Now, a lot of my theories and what I'm going to talk to you is based off some published beauty ideals focusing around face shape. Now, Maurizio De Maio has written a fantastic paper back in 2015 that beautifully summarized the beauty ideals between female and males. Now, in females, I won't go into this in detail, but I would suggest you get this paper and read through it. There are some key things that should be focused on to achieve a female beauty ideal. Heart to oval shaped face is a more desirable face shape across cultures, which we'll come on to. What that means practically is a greater bizygomatic distance versus a bigonial distance. They should be more prominent in their upper to mid face than their lower face. And female attractiveness lies in the cheeks. However, if we look at male faces, it's very much different. There's almost a square-shaped face is the male ideal, bizygomatic distance being equal to the bigonial distance, and more harmony between the upper and lower facial features. Male attractiveness lies in the chin. A good strong chin and jawline is an attractive male feature across cultures. With some exceptions, I know that there are some things in Southeast Asia where there is a focus away from male features, but we're looking in general that male attractiveness lies in a strong chin and jawline. So I'd like to take a minute there and hand over to Fabian to see if there's any questions we can or should answer now.
Yeah, Benji, there's actually quite a few questions, and thanks to the 2,100 participants who are already attending your webinar. So actually, some of the attendees pinpoint the importance of understanding patients' motivation when you assess them. And actually, the question is, how do you manage to interact with the patient, understanding their motivation, and then adapting your assessment and then your plan, your treatment planning to at the same time meet their expectation, and then for you, like do the best job that you can, basically.
Yeah. I mean, great question. Obviously, everyone, loads of smart people watching. I'm going to come to that, and it's a very, very valid and very important point. As I'll come to discussing that, patients' motivations and priorities are absolutely important. But what I'm actually doing as part of this, I actually leave that to the end. I believe in snapshot diagnoses that we should be doing to decide what is best for our patient before they actually open their mouth. So an example being, when I see patients in clinic, if I'm not welcoming in the waiting room, and then it's in my clinical room, I'm actually deciding, or I'm challenging myself to decide within the first 30 seconds to 60 seconds, what I'm going to do for that patient, irrespective of what they want. And I'm going to plant that in my head. And then actually I leave understanding the patient's priorities to the end of my consultation. And then it's about marrying the two together, which comes down to education. And I'll come to that very valid, very important point.
Great. So most of the questions are actually about the patient-practitioner relationship and how you deal with that. So I think because you are tackling this issue in the second part of your presentation, maybe we can go on, and then we will tackle those questions after the other part. Is that okay with you?
Absolutely. Absolutely.
Perfect.
So I think the next slide we have is the poll. So a quick set of questions here that are going to pop up on all your screens. I just want to get some answers and get some information from everyone that's watching to get an idea of where everyone's minds are at. So please take a minute just to look at this and answer this. And then what I'll do is in a few seconds, once we get the answers back, it'll be a good platform for us to discuss this and maybe raise some more questions. Because as I said, there's no right answer to all of this. It's about what works for us. So yeah, the first question is whether there's a facial assessment plan you use, and do you use it for all patients? Which type of plans are you using? Most common ones I've come across, I know there are other ones, is Arthur Swift, who is absolutely fantastic. Grandpa's, there's the MD codes. And then if anyone actually measures the face according to the golden ratios, do they use calipers, or do they apply any photography that maps out the face in that way? So hopefully we'll have some answers in just a second. Perfect. So, so in terms of results, really interesting results. So question one, if you usually use a facial assessment plan, do you use the same for patients? 29% answered yes, 72% answered no. So that means that the majority aren't using the same, or using and the same assessment plan for each and every patient. Number two, which facial assessment plan are you using? 4% are using Arthur Swift's Grandpa's, 42% are using the MD codes, and 54% are using others, which is really interesting data as well, because again, no right answer, and people get used to things and then make it work for themselves. And then number three, do you measure facial assessment according to the golden ratio? So 49% answered yes and 51% answered no. That for me is probably the most interesting thing, that there are a lot of people out there actually implementing the golden ratio. So thank you all very much for your answers. That is very interesting data to have. And hopefully some of that will be important as we go through. So let's carry on and let's talk about face shape. Now, I spend a lot of time trying to look through the literature, because for those of us that treat patients from around the world, we know that there are nuances and differences in terms of what patients want when it comes to face shape, most particularly in the Far East, where they do like a slightly rounder face. They don't want hollow cheeks or rounded cheeks. It depicts luck or good fortune. However, the most recent bit of data around globalization actually still demonstrates that oval and heart face shapes are generally the most desirable female face shape. And we're talking about female faces here, guys. We're not going to talk about male as part of this talk. Those are the most desirable female face shapes across cultures, generally speaking. This is down to social media, globalization, and I know, for example, seeing now Far Eastern patients, they are wanting more of a heart-shaped face than a rounder face shape. They are more open to stronger cheekbones and definitely strong chins than they ever have done. So I'm basing the rest of this talk off the basis that oval to heart-shaped face are the most desirable across cultures, generally speaking. Now, we know understanding face shape is central to beautification. Marquardt's mask, rule of threes, rule of fives, using the golden ratio, which half of you are practically doing, are therefore very important because it's helping you take yourself on a journey to understand what you should do to elevate those patients' ideals. So actually that data, as well as the fact that we have used things in the past, further strengthens the importance of face shape and proportion. Now, today's world, however, is also about emotional drivers and expressions. So we have to understand patients' perceived emotions and be able to diagnose those ourselves. So let's take it practically. In my world, patient walks in, 30 to 60 minutes, 30 to 60 seconds, the first of which of the consultation, we're talking to each other. I'm looking at that patient's face and I'm determining what I want to do. Then I'm allowing the patient to talk, and I give them free rein to say what they want to say. I don't ask very closed questions at the beginning, I ask them open questions. I'm trying to get information that talks about emotions. Patients very commonly at this point start talking about they're tired, they're sad, they're angry, they're saggy. They're the most common things that they use to describe themselves. Now, it may be very different for patients with a sort of clinics with a very young demographic, who are coming in for very specific things. But certainly from about the mid-30s onwards, patients are starting to see anatomical change in the face, which lead to negative emotional expressions. As injectors, we have to understand and link the anatomical changes to these emotional terms that patients are using to describe themselves. As if we understand the anatomy, we therefore now understand what we need to do to improve that. We cannot rely solely on face shape because negative emotions may be the patient's primary concern. If we don't address that, we run the risk of patient dissatisfaction. Now, the next important thing is patient education. So we have talked about two of the important things when it comes to treatment planning and consultation. One is face shape, second is emotions, and now we're going to talk about education. So human perception of facial aesthetics is highly subjective, particularly in social media. We tend to focus on what we're displeased with. This goes back to what I was saying earlier on. It's a feature we see every day in the mirror, and we want that addressed. This young girl wanted her nasolabial folds addressed. Patients don't understand anatomy, and they don't understand the aging process. So how do you, in this patient example, tell her you don't need your nasolabial folds, you need your tear troughs, potentially your cheeks treated? How do you explain that to her? And how does she need to understand that one syringe may not do the job? You may need 2 syringes. Should you be using words like the medial soothe, the lateral soothe, and the tear troughs? Will she understand that? We've got to go on that journey, which I'll take you through in just a second. We've got to do this without the patient thinking they just want to take our money. In this patient's case, if I had said to her she needed 3 syringes when she wanted 1, she would look at me as if I'm just trying to take money off her and I'm greedy. I've got to explain to her and make her understand why. Now, let me take you through my slides I use for patient education, which I believe is essential. And I show these slides, I've compressed them down for your benefit in every single patient consultation. So I've understood what they want, we've had a chat, and I'm going to talk to them about facial aging. It doesn't matter if they come in for the lips, it doesn't matter if they come in for one saggy eyebrow, it doesn't matter if they come in for the nose. I'm going to tell them about it because I will guarantee all of you, most of your colleagues in your area probably won't be doing it. So it will just elevate yourselves. I will talk about bony changes. Now I've got to make it understandable for my patient. I can't start using words like the maxilla, infraorbital, superior, inferior. I just talk very generically about the fact that as we age, we lose bone in some parts of our skull and we increase bone in some other parts of the skull. And this leads to certain things like a flatter cheek, saggier jawlines. It also leads to more tired looking eyes. They don't realize that these kind of things occur. I then talk to them about how fat changes over time. I tell them that a lot of the structure of our face is based off individual compartments of fat that we all have. And when they're full, we get beautiful full cheeks, beautiful definition. You've got to ask them to think about their children or adolescents. But as we age, we all see a change. And I talk about how the signs here, and around the jawline as a result of this descent of volume. Again, they don't understand that. So this now I'm starting to plant seeds in their head that if they're bothered about their jawline, actually, I need to treat their cheek, rather than me saying, I need to treat your cheek. Then I talk about skin, which we don't necessarily have to cover off. However, we talk about skincare. Teoxane has a great range of skincare products, which can, you know, injectable and non-injectables that can help elevate this part. And then finally, I talk about the difference between the male and the female beauty ideal, because I'm taking them on a journey to understand that if you're a male and I need to beautify you, I have to achieve some beauty ideals to help improve your aesthetic. So our goal is to help patients understand the need for facial proportion enhancement if required. If they don't have the right shaped face, how do we improve that? How do we give them structural support? And then finally, how do we beautify them? So as a result of that, that's a lot of the background, long-winded, forgive me, but I've developed a new facial assessment and treatment planning tool called TeoPlan, and I'd like to take you through this. So TeoPlan hopefully simplifies and condenses this down, and for those of you that asked, it helps manage the relationship with your patient. T, the first part, stands for total face assessment. This is what you're going to do first. E is the emotional assessment. This is you, the expert, assessing the patient's face and their emotions. 3 is O, it's order of priorities. This is your order of priorities. We're not thinking about the patient's priorities yet. What do you believe is the most important thing to treat? And then plan is a plan provided to the patient where you take into account the patient's priorities. So let's go through it in a little bit more detail. T, you're going to assess the face shape and the beauty ideals. Now, what that means is you're going to look at the face shape, what type of face shape do they have, and then you're going to assess each part of the face looking at those male and beauty female ideals. An example being, if a female has a very depressed lateral eyebrow, you know, a more beautiful female eyebrow should be elevated. There should be a gradient from the medial to the lateral aspect of the eyebrow. You're going to look at each third in detail. If a patient has an ideal face shape, oval or heart, what can you do for them? You know you don't necessarily need to modify their face shape because they have a beautiful face shape. You're going to look at their emotions. What does their face say to you? Is it tired? You may need to do little tweaks to improve elements to improve their, the beauty of the face. O, you're going to understand your priorities, and then you're going to ask the patient priorities. And do those priorities match? And we're going to go through some examples in a little bit, guys. Now, these kind of patients often just need refinement. So practically speaking, my patient earlier on, no nasolabial folds, tear trough, she had a beautiful shaped face. She looked tired. I wanted to treat her tiredness. I'm going to show her pictures. Does she agree with me? If she does, perfect. We're going to refine this area of the face. We're not necessarily changing the structure of the face. If a patient has a non-ideal face shape, so they don't have a oval or heart-shaped face, you're going to also assess their emotions. You're going to understand your priorities and their priorities. And these kind of patients, 2 sessions, shape modification and refinement. Now, if your priorities don't match, you're going to educate them. This is where you can change the game and change the outcome of that consultation. So if you have decided that they need their tear trough, their medial cheek and their tear troughs done, they just want their lips, you educate them. Once you've educated them, I would hazard a guess above 75% of them will convert to going on to have something else done. If they don't, that's fine. You've planted the seed for 6 or 9 months down the line when they may come back for it. You are potentially developing your patient base for the future. So the TILLON plan is based off 2 sessions. Session 1 is shape modification. This is where you're going to add volume and you're going to modify facial shape. The tools I like to use and the best tools I believe are the use of RHA4 and Ultra Deep. If not, you're going to refine them. This could either be session 2 or it could be the first session. And this is where you're going to refine areas to beautify and improve their beauty ideals. This could be the nasolabial folds, the tear trough, the lips, or fine lines. And this is where you may use other products like RHA 1, 2, or 3, RHA Kiss, or Density 1 or 2. So total face, let's go through this. If a patient has an oval face shape, they're actually doing okay. So you're going to refine them. They are going to be tear trough, lips, nose. They're going to be smaller elements you're going to improve. If a patient has a long face, you're going to have to widen their cheeks or their jawline to move them to a more heart-shaped oval face shape. So you're going to have to modify their shape first. So you use RHA4 Ultra Deep. A round face, really challenging faces for us to treat. They require a lot of volume. I've been there when someone with a round face walks in, it's a bit of a heart sink. But with the right plan, the right tools, understand anatomy, we can make changes. Now these patients require both sessions, shape and refinement. You need to lengthen the chin, you need to tighten the jawline, you need to potentially treat a masseter if you can with neurotoxin, you need to augment the lips. So now you're going to use a combination of Ultra Deep and RHA4 in session 1, and then some refinement in session 2. So you're going to aim to try and lengthen the face to make it look narrower. A square shaped face, you're going to either widen the cheeks or you're going to narrow the jawline. And even if you're not using neurotoxin, RHA4 Ultra Deep, beautiful product to try and improve that shape, often in the cheeks here. A heart-shaped face, they're doing okay. Individual subunits, you're going to be refining these patients to elevate their beauty. And then finally, diamond shapes. These are really difficult cases to treat because often you have to use a lot of product in the jawline to widen the jawline. And in a female, we're going to be really careful that we don't move them to a square shape. We still want a heart to oval shape. So again, you're going to use RHA4 Ultra Deep attention to the jawline. So here already we're looking at face shape, or I'm looking at face shape, and I have a plan of what I need to do at session 1 to start off with. Emotional assessment. So now we've done T, we're now looking at E. I'm looking at the patient's face. What is their face telling me? And I'm going to link it to anatomical targets or indications. So if someone's tired, often I'm going to have to address the lateral or medial cheeks, either deep or superficial compartments. I'm going to treat the temple and sometimes, the tear trough and sometimes the temple. If someone's sad looking, they may say that they look sad. This can often be reflected in a bit of sagginess or descent in the lateral medial cheeks, lateral eyebrow, marionettes, oral commissures, and lips. Someone's saggy, it often is focused around the jawline, but we know we have to treat the cheek. I call this SMAS modification because we're going to use, I like to use some RHA4 with a cannula in the subcutaneous tissue to modify the SMAS to create some elevation of the jawline. And then we're going to treat the chin, jawline, marionettes, and NLF as well. Angry faces, often focused and tension around the mouth and the perioral area. And this is where we can use potential refinement, plus or minus some, with some sort of RHA 2 or 3, potentially some RHA 4 to rebalance this area. So what does their face tell you that you need to treat when it comes to emotions? And finally, what are your priorities and what are the patient's priorities? So this is an answer to your question. I'm going to write down my priorities, and I've been writing it during the consultation. This is when I ask the patient. What I like to do is I like to give them a mirror. I ask the magic wand question. I say, if I had a magic wand, what are the things I can improve or remove based on priorities? Number 1 being your top one. This is where hopefully, you hope, the 2 match up together. If they don't match up, we're going to educate your patient. So I'd like to take that as a break there to see if anyone has any questions. So Fabienne?
Yeah, Benji, actually there's a lot of very interesting questions, and I'm going to ask you 2 of the questions that are a little bit linked, I think. So the first one is, how do you manage a patient who has had treatment in another clinic and a treatment that looks a little bit unnatural, and is coming to your clinic and ask you to keep on going with this unnatural kind of treatment? And then the other question, which I think is a bit linked, is how do you make patients accept that their own beauty, if you like, and explain that the treatment you're going to give is going to make them look beautiful in their own way, without going with some very specific, you know, like Barbie-like criteria, if you know what I mean.
Got you. Okay. Perfect. Yeah, I can understand that. A great question. So, I think the most important thing for all of us is it goes back to choosing your philosophy. So I go back to one of my first slides. I like to sit in a very natural looking outcome where I focus on facial balance, harmony. And that's what I want to achieve. Now, that doesn't mean that patients who want to come in and look unnatural, they're wrong. That's their perception of beauty. I choose not to deliver that. I think the best way to manage that is, number one, is don't criticize our colleagues that do it. So if they've had treatment elsewhere and someone has done that, we're one community, we're all there to help and support each other. First off, don't criticize that person as much as we can if possible. So I think we've got to really believe in that. Number two is, if they're looking for that outcome that you don't want to do, I will take them through this exact journey that I'm showing you guys. I'll talk to them about facial shape. I'll talk to them about the anatomy changes in layman's terms. And then if they're saying, oh, I just want more in the cheeks, I am very honest saying that I don't think that's appropriate. Now, there are two ways that can go. A patient can say, understand you, and they appreciate that honesty that they haven't been told before. If they definitely want that, I will say to them, I'll be very honest, that's not something I do. And you know, patients may complain about that. I've had complaints of me refusing patients based on what they want. But it's not even a risk. It's I think it's an ethical, moral thing that you have to be comfortable to do. So choose your line in the sand. Don't be afraid to lose patients. We want to treat the right patients. We want to get beautiful outcomes, because a good outcome means more patients coming in. A bad outcome that you can't keep happy, we'll go and tell everyone else. So I hope that answers some part of the question, and hopefully that answers some of helping patients accept their own beauty. So we all have those patients that come in and maybe overfilled, looking unnatural, and maybe they want to go in a different direction, or someone who's already very beautiful that wants to go down a route that you think is going to make them look unnatural. I go back to the beginning and I show them the pictures on facial shape, I show them the pictures on beauty ideals, and I show them the anatomy. And I've already told them more than what they've probably been able to research themselves or what they've been told in the past. And once they understand that, in my experience, most believe you, and you've created a patient for life for when they want and need appropriate treatment. There are some, however, that don't want to listen to you, and I do challenge all of you to watch out for red flags, things like body dysmorphic disorder, and note those things down in your notes. And again, if you're happy to do that, make sure you're prepared to deal with the consequences, because in my experience, a lot of these patients, there's never enough, and they're always going to be back for more.
Thank you, Benji. We actually have another question that is coming back from a few participants. How do you make the patient not feel like you're trying to make them spend more money when you actually identify some parts of their face that should be treated on top of the one they came for?
That's a great question. That's the most difficult thing to do. So the way I do it is educate them. So if, for example, there's two ways this can go. Someone's come in for the nasolabial folds, a very simple way of looking at it. And they have, maybe they haven't told you your budget, and I don't always ask the budget straight away. I will take them through the whole journey of why, if I'm going to treat this, potentially more than likely I would want to treat their cheeks as well. And I will write them, and then I will educate them on as to why I need to do that. I will write them out a treatment plan that breaks it down in sessions, and I will discuss the cost with them myself, me personally. And the reason I do that is then I can gauge what they're comfortable doing and what they're not. If they're not comfortable spending what you've suggested in session 1, you are the expert to modify that. you can say, okay, let's break that session 1 and down into 2 sessions. And then they're spending money that's more comfortable. If they continue to argue against the fact that you're trying to take more money, I will be honest and I say, look, I would rather not treat you at all than treat you with 1 syringe where I'm going to see no result. And again, it's because I'm not afraid to lose that patient. And once they notice that, they realize that you're serious. I will then also show them photos of cases I've done where I have used maybe 1 syringe or 8 syringes, and then they can see the differences themselves. And what I tell all of them, if they want to go down the 8, 9, 10 syringe route, this doesn't have to be done in one go. This can be spread out over a period of time. There's a treatment plan and sessions we can develop to help manage their budget. I think once you get that trust and confidence, they may not have treatment with you straight away, but they will be back for other treatment sessions as you go on. So yes, it's a very challenging thing to do. You're challenging someone's money. I use terms like, when I say I would rather not treat you at all, and I say that because your money, I want to treat your money like my money, which I do. And that's one of my philosophies with my patients. If someone wants to spend money and they're not going to get anything from it, I will say no, because I do not want them to spend money unnecessarily. Money spent unnecessarily leads to a bad review and a bad outcome.
Great, thank you so much, Benji. We still have a lot of questions, but we'll take them at the end so that we have time to go through all of your presentation. Thank you.
Perfect, thank you. So let's go on. Let's go through a few examples together. So let's put this into practice and see if it works for any of us. So let's take this young lady. She came into me and she came in and I looked, remember I'm doing my assessment first. I look at her face shape and I believe she's got a long to oval shaped face. Immediately, I believe to modify her facial shape, I need to treat her lateral cheeks. I then go through each third, analyzing her face from top to bottom. And I look at each third and I look at the fact that in her anterior cheek, she definitely needs some volume. She needs some treatment of a tear trough potentially. Upper lip is a little bit out of balance with a lower lip. You can particularly see that on profile. As my dental partner would say, she's definitely got a malocclusion. And you can see the outcome of this in a soft tissue. And she's got some evident oral commissures. We look at her emotions. She looks tired to me. She says she doesn't feel tired, but she looks tired as well. So I already noticed she looks tired. Her anterior cheek, her lateral cheeks, and her tear troughs therefore need to be treated to treat this negative emotion. My order of priorities, therefore, is to make her look less tired, treat her under eyes, treat the corner of her mouth, and balance her lips, which matches perfectly her priorities. So we've got a beautiful synergy between what she's expecting and what I am. Now, therefore comes the decision where we have to write out a treatment plan. So my treatment plan for her and what I actually delivered was session 1, treating a lateral cheek, understanding the anatomy that I need to treat a lateral tooth, and I choose RHA4 and I use a needle in this circumstance. I didn't want to use ultra deep because she's young. I didn't want too much projection and to widen her cheeks too much. So I used RHA4 with the needle. I treated a medial cheek, targeting a medial tooth with RHA4 using a cannula. It's my preferred approach. So this was my session to modify a shape. Session 2 was refinement. This is where I'm going to come and put the cherry on the cake. So I went to treat a tear trough deep with Redensity 2, and I like to use a cannula when I treat the tear trough. I treated an upper limb to improve some balance with RHA3 and a needle, and these are the results we got with 4 syringes. I used 2 syringes in her session 1 where I modified her shape, and 2 syringes in session 2. Now I had made the plan for her treatment within the first few minutes of meeting her. I just needed to get her on my journey, which thankfully she was. Now, when I wrote out the plan and the cost, I wrote out a plan for 2 syringes for the session 1 and 2 syringes for session 2. Now, what I don't like to do is talk to my patients about number of syringes. I like to talk to them about the outcome. So how could I achieve the outcome in session 1 and in session 2? I believe she needed 2 syringes. The way I price my treatments is that if I needed to use another syringe, maybe a 5th syringe, she comes back, she's a little bit unhappy, I give that to her for free because I priced it in a way that allows me that flexibility to do any top-ups if necessary. So this was an outcome with 4 syringes. And you can see the balance in her, her facial shape, which is improved, her medial cheek, her tear troughs, and the balance now in her lips and her lower face versus beforehand. Example 2. So this is a patient, a beautiful lady, came in. I looked at her face shape. She has a heart-shaped face. She's got a beautiful face shape. So I'm now looking at face. I don't need to do any major structural shape modification. But now I look through each third. I noticed the fact that she could definitely do with some improvement anterior cheek and tear trough. She could definitely do with some volumization on her upper lip and her labiomental crease. I look at the emotions her face projects. She looks tired. Therefore, I need to treat anterior cheeks and tear troughs. I missed out the lateral cheek because I don't want to over-project her laterally. And finally, my priorities were to make her look less tired. Her priorities, thankfully, were just the same. So treatment plan, she was shape and refinement in session 1 almost. So she was medial cheek, medial sooth, RHA4 with a cannula, tear trough, deep redensity 2, total of 2 syringes, which was a very achievable budget for her, and we got some improvement under her eyes. Now, she didn't want to have her labiomental crease. She didn't want to do any of this here. I educated her on that, but she chose not to do anything with that at all. But she got a beautiful result anyway. Example 3, patient comes in, total face or shape assessment. She has a square-shaped face. She's got this characteristic bottoming out that we see. Therefore, she's got a square-shaped face. We need to treat the lateral cheeks. Her chin, need to treat inferior chin to make her face look skinnier. And I'm going to do that SMAS modification to create some lift and some narrowing to the mid to lower face. We're going to look at each third. A lateral eyebrow could definitely do with some elevation to improve the gradient from medial to lateral. Anterior cheek could do with some volumization. Tear troughs, jawline, and lips. She looks tired and saggy to me. Therefore, I need to treat her lateral anterior cheeks, preauricular area or SMAS, her chin and her jawline. These are the things that I've noticed based off her emotions. Now, my priorities were that she needed to look less square, but she didn't want anything done with the tear trough, which is one of my top priorities. She wanted to avoid any filler in her eye at all, for reasons we didn't quite get to the bottom of, but I think she may have had a friend who had a bad result, and she didn't want to go down that route. I wanted to treat that, but I also wanted to make her look square. I educated her. I told her about the fact she looks tired. I told her about the fact that there's probably some volume loss in medial and lateral cheek compartments, but she was adamant, which is fine. But I planted the seed for her tear troughs, and I have confidence that I believe I just treated this patient relatively recently. She will be back in a few months' time to have her tear troughs done. So anyway, session 1 for her was lateral cheek, and I use ultra deep in her case because I needed that projection. Medial cheek, I use a cannula with RHA4. Preauricular, modifying the SMAS to create some lift. This was RHA4, and I use a cannula in the superficial plane. Inferior chin, super periosteal, and I use ultra deep needle to get that projection. And then session 2 was refining her lip, just to add a little bit of balance with RHA2 and needles. So a total of 7 syringes. And what we've achieved is a narrowing of her face and a reproportioning from her lower face to her mid face without anyone thinking she's had any fillers done. We did it in 2 sessions. I showed her before and after before she got going, and she was happy to pay for these sessions. Last patient, this patient has a heart to square face. Therefore, I need to improve her lateral cheeks and her chin. Each third, you're going to go down temple, eyebrow, tear troughs, medial, lateral cheek, NLF, jawline, labiomental crease, jowls and lips. Lots of things to potentially correct in this patient face to heighten our beauty ideals. I look at her face. To me, she looks really angry, really, really angry. A lot of tension focused around her perioral area. So therefore, things I need to address are chin, labiomental crease, marionettes, oral commissures, and lips. My priorities, I wanted to treat the whole face. I wanted to do everything from top to bottom. Her priorities, she just wanted 2 syringes and she just wanted her cheeks done. She'd had treatment elsewhere in the past and she just had treatment in cheeks and she really liked it, and that's all she wanted to do. I had to educate her, and this was an hour-long consultation on all the changes she's seeing in her face. I took her through that photo of how the fat changes, the bone changes, and the skin changes in her case as well. And she therefore opened up to having her mid and lower thirds treated, because so I used the word angry, and I used that word openly with her. She noticed the fact that she looked angry. She said, actually, that's something she's thought about in the past, but she didn't know there's anything that could be done. But she didn't want to do anything at her lips at this point. So I moved her thinking from 2 syringes to potentially a greater plan. And actually what we did for her is in session 1, we did all of this. Ultra deep needle, lateral cheek. Medial cheek, I use ultra deep with a cannula this time. Medial cheek, superficially RHA4 cannula, so the sandwich technique. Labial mental crease, RHA4 with a cannula, and jawline with a cannula as well. And then in session 2, tear troughs, deep, and redensity 2 with a cannula. And this is where we just refined her to finish her off. This was a few days after a second session, and you can see the balance we have in her face now. She looks so much less angry. She also went on some skincare from before her first session of fillers, and you can see the change we made to her. 8 syringes we used, which I do understand and respect is a lot of filler for a lot of people to use, but she believed in the outcome, and she was actually, once I got down to it, was toying with a facelift, but she didn't want to undergo surgery. So when she toyed up the price of what I charged her versus a facelift and not go through the downtime, she was open to that outcome and that journey. So the key to all of this, as I go back to the beginning, you can see from all of this is understanding anatomy, understanding how an indication relates to the anatomy, relates to the choice of technique and product. If you understand those, all of this, I think, makes a lot more sense. So in conclusion, I believe, and I use this day to day, this is simple and reproducible. It may be a lot to, you've been hit with, and hopefully in the future we can go through it in more detail again. But hopefully it's stimulated some thinking. I use it simple and reproducible for myself, but also for my patients, because I'm taking through the TO plan. It's grown my business and ensure patient satisfaction because it educates my patients and it gets good outcomes. It's easy to teach to associates. So taking on an associate, I'm going to make sure he does this. If we're both doing the same things, we can replace each other as and when. If I go on holiday, I know my consultations are going to be exactly the same with him as how I do it, and vice versa. So we can fill each other's shoes. And you must ensure you know your ATP. So with that, I'm finished. Thank you very much for those of you who have tuned in and listened, and we can go to any questions.
Thanks a lot, Benji. We still have a lot of questions from the 2,100 participants who attended your webinar today. So thank you, everybody. So you showed during your presentation how to adapt to the different shapes of the face, but there was a question on ethnicity. Would you have some tips to adapt depending on your treatment, your assessment, depending on ethnicity?
Sorry, you cut out there for a second, Fabian. Sorry, could you repeat that?
Yeah, sorry. So the question was, beyond the face shape, do you have some tips to adapt your assessment and then your treatment depending on ethnicity?
Yeah, so absolutely. So as I mentioned earlier, I believe there's a globalization of beauty that's happening very, very quickly. So if we take, for example, in Western Europe, we know that they definitely want that more proportion in the middle third versus the lower third. They're definitely going over for that heart to oval shaped face. In the Far East, where that wasn't desirable, I believe it's becoming a lot more desirable than it has done in the future. And then if you look at, say, the Middle East, again, a heart-shaped face or an oval-shaped face is very desirable. You've only got to look at the social media stars and the actors and actresses from that region to see that. There are, however, nuances in the detail between those 3 areas as an example. For example, in the Far East, although they still want to get that heart to oval shaped face, they definitely want more of a defined, more exaggerated chin point than maybe they do in Western Europe. In the Middle East, although they want an oval shaped face, they definitely, so I assume from my experience, is a much stronger definition to their jawline than we probably do in Western Europe or the Far East. So you're absolutely right. There are some nuances and some little details that you have to be sensitive to between ethnicities.
Okay, thank you very much for this answer. We also have a question about the relationship with the patient, like, because as you mentioned earlier, sometimes you are going to go beyond what the patient is asking in terms of treatment because you notice something else. So how, if this patient, if you do this treatment, but then the patient is fixating on it and coming back unhappy, if you like, how do you manage these patients?
So, sorry, I'll just repeat that question. So if a patient, if we treat them in a way that they didn't want, but they come back for what they wanted, how do we manage that? Is that the question?
Yeah, basically, if the question is, how do you manage a patient who returns kind of a little bit unhappy or upset with the treatment because it was not exactly what they expected?
So this comes back to matching priorities. So I've got my priorities and I've got their priorities. So for example, very broadly speaking, if I've said they need their, I'm just very generic, their cheeks, their tear trough and their lips, for example, and then theirs is lips, lips. I'm going to educate them. Why? I'm still going to educate them. I'm going to be bold. I'm going to be position myself as the expert, why I look at these things and why I've got this priority of list and explain that to them with the educational slides I showed you. But if I don't get a feeling that they understand that or they want that, listen, we'll still treat their lips based on their priorities because that's what they want to achieve. So that's where the detail in the consultation is, where you've got to get these cues and these signals off your patients are still very important. If I can get them to agree on my order of priorities, and I've got that in my notes, got that written on the treatment plan, and they walk out happy and they book in for that first session, they're in agreement with me. If they're not, then you've got to take into account their priorities. Now, what you've got to bear in mind there is, for example, if lips is their priority, but you feel like treating their lips is going to make them look unnatural, that comes back down to your philosophy. How comfortable are you doing that? Me, example, if I don't feel their lips are needed to be done, I'll be honest with them. They may go elsewhere, but that's fine. You know, that doesn't happen often. And you're just going to be comfortable with that decision.
Thanks, Benji. We actually have a bit of a more technical product-oriented question. Could you explain what for you is the difference between how to choose between injecting with ultra deep or RHA4?
Oh, great question. So for those of you that know me, RHA4 is my favorite product in the world. I use it everywhere. But there are indications where RHA4 isn't the best product. When I would use ultra deep, so ultra deep should always be used supraperiosteally. Never use it, in my opinion, superficial plane. Always use it on the deep plane onto bone, but to deep compartments. So therefore, if you are treating more superficially for volumization or lift, RHA4 is probably your first product. But for example, if we take the cheeks as an example, why would I use ultra deep or RHA4? I would use ultra deep if I need to get really good projection and I need to use less volume than RHA4. Ultra deep will give you that. Okay, so that's number one. Number two, when I wouldn't use ultra deep is if they've got a thin skin envelope or they're very gaunt and very cachectic. They don't have a lot of subcutaneous fat. The risk with ultra deep is it could show up, it could show, and it could look a bit obvious. Therefore, I'd use RHA4. So I take the skin into account. Temples is another very good example. Ultra deep is a fantastic product for temples, but if they're very skinny, you've got to be careful about considering ultra deep. I would go to RHA4. But in a lot of patients with a thick skin envelope, where you're trying to really good projection, ultra deep is your go-to product. So hopefully that answers your question. Really take the skin and what you're trying to achieve as an outcome into account.
Well, thank you very much, Benji. I think we have time for just a quick last question. And because it's been asked quite a few times, what for you would be the optimal time between sessions?
Oh, that's a good question. The optimal ideal time, in my opinion, is 3 weeks. sort of 3 to 4 weeks, I like to say, because I believe it takes about 3 weeks for everything to settle in, for the filler to start having its effect. So I like to retreat them at that 3 to 4 week period. You get some patients that want things done in 1 week, which is fine because they've got an event. But 3 to 4 weeks is my ideal space between sessions. Now, if, for example, someone can't afford session 1 and session 2 that close together, which is also very important, 2 months is absolutely fine, because if you look at 2 or 3 months as a time difference, it's not really going to make a difference in terms of how quickly or long the products degrade and how quickly the effects wear off. So 3 weeks at a minimum, say 3 months at a maximum.
Great, thank you so much, Benji, for this amazing presentation and for answering all these questions. Thanks to the up to 2,200 participants who attended today. And we are hoping to see you all on Thursday at 1 p.m. Paris time, when Dr. Patrick Trevidick will talk about a new area of treatment in the lower face. So on Thursday, the 23rd of April. Thank you so much, everybody. Thank you so much, Benji. Have a great day.
Stay well, stay healthy. Bye.
Bye. Stay safe.